Thank you. So welcome everyone. Welcome to the National Health Council's webinar on nutrition-related quality measures. How might they improve care for people with chronic conditions? We really appreciate you being here this afternoon. Silke, would you switch to the next slide, please? Just want a reminder that this is sponsored by the National Health Council, and we want to recognize all of our patient group members and the great work that they've been doing, especially this past year when it comes to all of the support that they've provided their constituents during the COVID pandemic. Next slide, please. So a couple of housekeeping items. Just want you all to know that this webinar is being recorded, and after it's over, it will be available on the NHC website. All attendees are automatically muted and they cannot mute themselves. And so please submit your questions and comments through the Q&A function. Next slide, please. Our objectives today are to discuss the interplay of nutrition and quality measurement and highlight topics such as what are quality measures, especially in nutrition, and provide real-world case examples of what's going on in nutrition quality initiatives. Next slide, please. So it's my pleasure to introduce the speakers for this afternoon. So we have Matt Pickering. Matt is the Senior Director of Quality Measurement at the National Quality Forum. And we also have Sharon McCauley, who's the Senior Director of Strategic and Quality Measurement at the Academy of Nutrition and Dietetics. And then last we have, certainly not in the least, Christy McNichol. Christy is one of our partners from Avalier Health, and she's a practice director there. So we have a lot to talk about this afternoon, and I want to leave plenty of time for Q&A. So we're going to jump right into this. And Matt, we're going to start with you.
Great, thank you. And just to double check, I'm coming in okay?
Yes, you sound very clear.
Great, thank you. So thank you very much, Eleanor, and thank you everyone that is attending the meeting today. It's a pleasure to speak with you all. So as Eleanor said, I work at NQF, Senior Director at the National Quality Forum. And what I wanted to at least tee up for you all in the discussions today is sort of the landscape of quality measures and thinking about quality measures specifically around nutrition-related quality measures and what we currently have, as well as far as endorsed quality measures that are used as well within maybe CMS programs. But before we get there, just a little bit of background about NQF. If you're not familiar with the National Quality Forum, we were founded in 1999 really as a public-private partnership to really promote healthcare quality within the United States. And since that time, we have done a lot of various different initiatives to do so. And largely it's been our consensus-based efforts to endorse quality measures that CMS, the Centers for Medicare and Medicaid Services, utilizes within various different quality improvement programs. And if you go to the next slide, you'll see some of the efforts that we do are to endorse those measures. And we convene various different stakeholders to provide consensus on the endorsement of those measures. You can see there's 600 plus measures across various different clinical areas that are NQF endorsed. We also have a Measure Applications Partnership, or what we call the MAP. The Measure Applications Partnership is also another effort that is separate from our consensus-based endorsement work, in which we convene stakeholders to advise CMS on the gaps within certain programs, the quality improvement programs that these measures are utilized in. What are those gaps based on the needs and priorities that CMS outlines, and potentially evaluating measures to recommend to fill those gaps. So that's an effort that we also do. We also have the National Quality Partners, which looks at critical health and healthcare topics, identifying and forecasting what may be coming down the pipeline for NQF and others to really look at it and think about to strategize around different efforts. We also do various things with measurement science, thinking about improving the measures. So thinking about reliability, validity testing, or efforts within risk adjustment and patient-reported outcomes and patient engagement within measurement. And we also have our Measure Incubator, which tries to incubate concepts and connecting various different stakeholders together to develop the measures around those concepts. So since our founding in 1999, we definitely have integrated ourselves across various different efforts within the healthcare environment and the healthcare landscape to try to promote healthcare quality, and largely doing that through advising on endorsement for measures, as well as advising on the use of those measures within programs. Next slide. So we do so with the endorsement effort to look at, we have standard criteria in which we endorse those measures. And those criteria evolve over time, and they evolve to meet the demands and the changing healthcare landscape. So we think about new methods and new approaches to measurement, new data sources that are used in measurement. Our criteria and those standards evolve to meet those demands and those changes within the healthcare landscape. Next slide. So currently here are our criteria, sort of those standards that we look at measures. And there's really 5 big ones, 5 major standards that we look at or criteria. One is the importance to measure and report. And so this is to show that there's evidence to support the measure, evidence to show that this measure actually there is a gap in care that this measure can actually fill. And so we're looking at evidence around the association of a process to a healthcare outcome that can be improved by this measure. And we're also looking at the gap as well. Is there actually a real gap in care and the variation across providers or the accountable entities that this measure is assigned to? In addition, we also want to consider the scientific acceptability. So is the measure reliable? Is it valid? And so there's the scientific acceptability of those measures as well that we need to consider. Is the measure feasible to implement, or are there difficulties in potentially implementing the measure or reporting the measure is another criteria. Its usability and use. So now that the measure, we know it's important, we know that the measure is reliable and valid and also feasible, can the measure actually be used? And can the data for what's being reported actually also be used to make further improvements in the healthcare system? So can those accountable entities that are being held accountable to that measure actually use those data in ways that they can actually improve the care? And so that's the usability and use section of our criteria. And then comparison to related and competing measures. We understand as we have developed, or excuse me, endorsed measures, and there are more measures in development. And you saw on the previous slide, there's 600 plus in NQF endorsed measures. We recognize that this is measurement burden that we're getting into. And we want to ensure that there's harmony across the different programs that these measures are being used in, and they're not competing with one another. So we're not increasing the burden to the system. So those are elements that we also want to consider. And those are the major areas of standards that measures that come through NQF are held against. And if they pass on each one of these, then they are NQF endorsed and potentially can be used within CMS programs. Next slide. So in this slide, and the text may be a little small, so apologize for that. But in just looking, and you can easily go onto our website and use our quality positioning tool. It's a find measures feature within NQF, and it lists all of the measures that have come through NQF as either endorsed or even when endorsement has been removed. And right now, for nutrition-related quality measures, there's 8 NQF endorsed measures currently. And they span different types of care settings, as you can see the accountable entity and care setting listed there, from your facility, so your hospital level, to your health plan level. There's one for individual group practice. There are also 3 outcome measures as well, and there are 5 process measures. So outcome measures being more of those types of meaningful measures we're trying to get towards as measuring outcomes as opposed to process, but there are 3 of those. And I wanted to show this slide to think about, we have 600 plus measures, and we're trying to have measures fill needed gaps in care. But when we're looking at nutrition-related quality measures, there's this perceived gap that there's really not a lot of those nutrition-related measures for things like malnutrition, or even looking at more of the adult populations as well. And I think it speaks to some of the importance of malnutrition and the gaps in care that currently exist in measures that potentially are needed to fill those gaps, which my colleagues Sharon and Christy will talk about as well. Next slide. And I just wanted to hone in on one of those measures, which was NQF 0024. This is the weight assessment and counseling for nutrition and physical activity for children and adolescents. I wanted to make mention of this because this is, of those measures that you saw previously, this is one of those measures that's actually used within a CMS program. And so you can see the description of this measure, but really is looking at three different types of documentation or counseling procedures that happen. It's the BMI documentation has been done, or counseling for nutrition or counseling for physical activity. Again, it's used within the core set, Medicaid core set for children and adolescents, and it's also used within the marketplace of QRS, a quality rating system. So the use, again, of this measure, as it comes back through maintenance evaluation. So NQF also does this maintenance review to ensure that the measure still meets our criteria. And we do that every 3 years. And what we look at is that part of that use and usability is if the measure is being used, which in this case it is, are we seeing any change over time? We want to make sure that that measure is actually having an impact. It's moving the needle. And if it's used in a quality improvement program, is it actually doing that? On the next slide, you'll see rates that the developer has provided, and these are small, from its last measure evaluation. Now, this measure is not up for another evaluation until 2022, but you can see that even from its last measure submission, which is around 2017, they've reported rates of each one of those different types of processes, those screenings or counseling processes over time. And we can see, and these are small, but we can see based on the different age populations, again, it's a children and adolescent measure, you're actually seeing improvements over time from 2014 to 16 across each one of those. So the rates are increasing. And for this measure, we do want to see those rates increasing. And I show this because there is a incentive, right? When measures are actually used in those programs to actually improve care. So if there are measures that need to be developed to fill gaps and that are important, especially with nutrition, using those within programs can actually drive improvements in care. And as we can see in this example. Next slide. And CMS is really trying to align measures based on its new measurement framework or its new measurement action plan, which you see listed here. You can find on their website. They just released this this past March, excuse me. And really the goals that they're trying to achieve through measurement relate to having high quality measures, aligning those measures across various different healthcare systems, prioritizing outcome and patient reported outcome measures, as well as measures that are using more digital types of data sources, so electronic data sources, and as well as measures that are trying to get to improving disparities in care. So measures that are being developed and endorsed are trying to meet these goals, and CMS is looking at those to align those within their programs with these goals. And next slide. And I'll just close here just to talk about new measure development. And Sharon and Christy will definitely get into this area for their presentation. But this is a new measure that is currently being considered for endorsement right now. And it's a composite measure. It is an e-measure, which is an electronic clinical quality measure. So you're thinking about digital measures. This is one of those measures that would align with that goal that just CMS has. And so it's based on 4 different types of measures that you can see listed there. But again, it is currently under NQF endorsement. And if we're thinking about those gaps currently of nutrition-related quality measures, this definitely would align with those gaps. It has been reviewed by our Measure Applications Partnership as well, that body that advises CMS on gaps in their programs and where measures can fill those gaps. And that group recommended conditional support for this measure. And conditions really were pending NQF endorsement. And so there is a lot of interest both from our MAP, and it's also under current endorsement consideration right now, to have new measures to address these malnutrition areas within our healthcare system. And I'll turn it over to Sharon and Christy to go a little bit deeper into this as well. So Sharon, I think you're next.
Yes, thank you so much, Matt. And thank you to Eleanor and to the National Health Council for inviting me today. And we, as Matt indicated, Christy and I are going to walk through real world application that confirms the nutrition quality measures do improve outcomes. And so with that, I'd like to change the next slide, please. Thank you. And so we're seeing, as Matt has indicated, how nutrition and health are linked 100%, and that nutrition plays a critical role with maintaining good health. I can not help but indicate that this morning I heard the CDC director, Dr. Rochelle Walensky, declare that this is a serious public threat about the diversity and the health and those issues, and that has directed all the different areas in the CDC to make sure this is a #1 priority, and nutrition is right there. You can see here on this slide that we have different areas of that play into it. These are not all of them. And so I can also indicate that we just received an estimation that about $580 million per year is spent on high priority diseases. And some of these here are listed. So that's a huge financial burden that we spend on some of those areas. Next slide, please. Thank you. So for nutrition and chronic conditions, I do want to indicate that, again, proper nutrition is that modifiable risk factor. And it is, again, in all those areas of cardiovascular, cancer, respiratory, diabetes are just some. Our registered dietitian nutritionist, that RDN, does work day after day, and they are clinically qualified nutrition and health professional experts that are totally involved with all of their patients. They lead, and they are really that individual that improves the patient's nutrition security, food safety, and health status. And they work alongside the interdisciplinary team members and are integral providers of those issues and these conditions that nutrition plays a huge factor in. Next slide, please. Thank you. For nutrition interventions, this is key. The nutrition care process and workflow elements that the registered dietitian does work to continue. We have screening, assessment, diagnosis. You see the intervention plan of care, monitoring and evaluation, discharge planning, and transitions of care. These are the things that we as registered dietitian nutritionists work on with all of our patients. And you can see some of the other things that were highlighted there. We counsel, share decision-making, goal setting. We work with lifestyle coaching. And then we have clinical privileges, and we do diet order modifications, and we make sure that we're totally involved with enteral and parenteral nutrition. We handle items such as medical foods when they're needed, oral nutrition supplements. We connect all the food resources in the community, post-acute care, as well as in acute care, and we do the whole spectrum of care. I can tell you that with these nutrition interventions, those registered dietitian nutritionists, the RDNs, are very patient-centered and are based on shared decision-making with their patients and their advocates in all the areas and the continuum of care. Next slide, please. Thank you. For a little bit about malnutrition significance and the Malnutrition Quality Improvement Initiative, we began working at the quality management area at the Academy of Nutrition and Dietetics and looking at us being a nutrition steward, at a measure steward back in 2011, 2012. And we continued on establishing our goals, and we felt that one of the major issues that crosses all the spectrum of everything that the registered dietitians do in all those areas that you have seen in the previous slides, that malnutrition is key to making sure we bring this to the forefront because it has a significant gap. As you can see, 20 to 50% of the patients are at risk who come into the hospital or are malnourished. As they're in the hospital, many times, depending on the gap that happens, that the hospitalized patient, because of maybe they were not able to be seen because of their items that have happened to them on an acuity that they end up being undiagnosed. There are many times when they're moved to the next point of care and we haven't been able to stabilize them and they end up having a readmission. I do want to go over some of the overall aims of our MqiI, which was branded and established in 2016. And we came together with Avalier Health, the Academy of Nutrition and Dietetics, to make sure that we wanted to really pull together quality improvement processes, data science, healthcare delivery, and really guide our registered dietitian nutritionist and all of their other paraprofessionals they work with, the technicians and dietary assistants, to really impact how they work and communicate throughout the whole continuum of care, and to make sure that they bring nutrition and those quality nutrition measures to the forefront in public health, safety, and quality outcomes. Next slide, please. So prevalence of malnutrition across all the practice settings. When we first came together to identify those measures that we established, we brought together stakeholders in 2 dialogue sessions in 2013 and 14. And when we did that, we came up with about 6 concepts for malnutrition and those measures. We ended up with 4 great measures that have now become the composite score. So with that, we continued not only understanding that we have pre-admission, we have our admissions, we were trying to make sure that we identified individuals who were discharged, we had great discharge planning, and we're making sure that the next point of care, that those areas are really highlighted. So we did, again, come up with another group of stakeholders that were brought together for another dialogue on transitions of care. And that happened in 2018. And what we found is, if again, you can see some of the indications of the prevalence in acute care, post-acute care, and community care. You can see that, many of you are well aware of our obesity and overweight issue. The 70% of our adults are overweight or obese, and that many of our individuals over 50 are not getting enough protein a day. Next slide, please. So in this dialogue session, we did focus on developing real-world solutions. And as you can see in this slide, that we really honed in on social determinants of health, disease, and chronic conditions, all of the population health management. And again, we really made sure that we were following the patient through admission, acute care, discharge, maybe back to readmission, or do they have malnutrition that was diagnosed? If they were at risk or actually malnourished and they had the interventions occurring in the hospital, they moved to maybe a rehabilitation center and post-acute care or out in the community. Do they have all the services they need? So our registered dietitian nutritionists are following those pathways. As well as you could see that we have identified that the US economic burden of disease-associated malnutrition is about 157 billion annually. And our key takeaway is that nutrition status is missing to make sure that communication happens across the continuum of care. Next slide, please. I wanted to highlight a few of our areas where our malnutrition quality improvement has been extremely successful. And Christy will continue and really fine tune and get into some of the real details of what we did and how we handle it. But we pulled together a supplement in our Journal of the American Dietetic Association in 2019. And I'm proud to say, as the guest editor, that 88 authors came together for this supplement to be pulled together. We have 8 articles all about all of the background of the MqiI, how our toolkit was piloted and demonstrated to be valid, as well as public policy issues were highlighted, our electronic clinical quality measures, and there's pilot programs, a learning collaborative, and all the practice applications, as well as great clinical leadership that our RDN stepped up and really worked with all those facilities. We had great abstracts and real world experiences that were highlighted. Next slide. Thank you. So our MqiI, our results keep coming. These are some of the ones that we have published, and these great publications really show you the evidence that we have. We, as I said, under research, we worked with Vanderbilt and did a pilot study on our quality improvement toolkit. When we were working on those measures and we were going through all the process of testing those and handling everything, I can tell you that we work with electronic health record companies. We tested them with about 6 facilities, as well as 3 that really honed in on the measures. But this toolkit was something that we really needed to do. CMS made that recommendation. How do we help our individuals on the ground to really implement these measures, give them resources. And that's what this toolkit did. And that article really expands on it. We also made sure that all the quality measures for malnutrition are publicized and in our journal. And as you can see, the latest is the Aspen article that we published about our 27 learning collaborative groups of individual hospitals that came together in 2017 and 2016 and 2017 that really worked on it and are continuing and doing great work. Next slide. And here's more that keeps coming in. I just wanted to show that we just published in Articles in Press the development and evaluation of our global malnutrition composite measure and the process that we were going through. I also want to highlight just in February 2021, we did use all the information about some of our registered dietitians who are really leaning and working tirelessly through this whole COVID, and they really stepped up and made sure they did pivoting, and they did adoption of telehealth through nutrition care, and that was also a great publication. And to make sure that we understand that malnutrition and our MqiI really is in real world. We did have the Hospital Improvement Innovation Network. There's partnership for patients that CMS awarded 16 organizations to be those HINs. The American Hospital Association with the Health Research Education Trust came together, and over 1,600 hospitals in 32 states really worked on their goals to decrease harm for patients by 20% and readmissions by 12%. And you can see that they coined in malnutrition as one of the big change management issues that had to happen to meet those needs. And they utilized our malnutrition quality improvement initiative to do so. And so next slide, please. And with this, I'm going to now turn it over for Christy to continue telling you more items that we've done and been able to accomplish with the Malnutrition Quality Improvement Initiative. Christy?
Thank you, Sharon. I hope you all can hear me. And thank you, Eleanor and NHC, for this opportunity to join you in this discussion about one of my favorite topics. So thank you, Sharon, for passing the baton. So in the spirit of elevating malnutrition as a quality issue, particularly among older adults, we had an opportunity to partner with Defeat Malnutrition Today to take it to the next level. In 2017, thereabouts, a multi-stakeholder group was assembled to develop an actionable document outlining what it would take to achieve quality of malnutrition care for older adults. The goal was to really, in truth, to provide the Trump administration at this time a blueprint for specific strategies to reduce or prevent malnutrition in older adults. And in that document, we targeted 4 specific objectives: improve malnutrition care quality, improve access to high quality malnutrition care and nutrition services, generate clinical research on malnutrition care, and quite frankly, advance public health efforts to improve malnutrition care quality. And since its release in 2017, some of these recommendations have actually come into fruition, as evidenced by some of our ideas actually being addressed in the 2019 GAO report on nutrition assistance programs, and then again in 2020 with the Older Americans Act reauthorization. Needless to say, we're thrilled. In 2020, we updated this document, and we took the time to specifically note the role that COVID-19 pandemic has played in exacerbating older adult malnutrition. And this is particularly related to social isolation. And as a result, there's been an intensification. So one can only hope that some of this will be ameliorated with the advent of COVID vaccines, but nevertheless, the impact has truly been real. So next slide. With the focus on MqiI that Sharon described earlier, and in the context of this national blueprint and its call to improve malnutrition quality, I wanted to provide a bit more detail about our program. as a national QI initiative, we chose to implement a dual-pronged approach focused on closing the gaps in quality and achieving malnutrition standards of care. It was a laudable goal, high aspirations, but we thought that in order to achieve this, we would need to have available two critically important components. One, a toolkit, and two, a set of measures. And in this case, to kind of be on top of the vanguard of where measurement was going, we sought to create electronic clinical quality measures, or ECQMs, and that's how I'm going to be describing them going forward. So these tools mutually support one another in helping hospitals support malnutrition quality improvement. We're very proud of our toolkit as it reflects a tremendous set of resources to guide hospitals through this entire process of improving malnutrition quality. Built upon the foundations of traditional continuous quality improvement methods, it actually helps teams identify gaps in current care practices and provides information on what malnutrition practice standards are, and quite frankly, how to implement them in order to fill those gaps. ECQMs, on the other hand, were designed to assess alignment of malnutrition care practices with established quality goals and best practices. And it is through our ECQMs that it allows users to actually track changes in quality of care, and then identify other areas where gaps may remain to target for future education and training. So the big picture, it is envisioned that hospitals, in using both the toolkit and the measures, will be able to meet quality measure standards and optimally improve the quality of care for patients. So on the next slide, I want to tell you a little bit about how we're making this happen. How are we creating a stir in the environment? We created in 2016 the Malnutrition Quality Improvement Learning Collaborative, and it in fact represents a movement. It was a way to raise awareness about optimal nutrition care among older adults and truly serve as a platform to bring together leading hospitals and healthcare systems across the United States to support the acceleration and dissemination of best practices for patients. So our participants each have taken on a data-driven, patient-centered malnutrition QI project and have been encouraged to use both the toolkit and the measures, again, bringing back this dual-pronged approach. And so data reported from the ECQMs have actually been able to help hospitals demonstrate their success in meeting those standards. And so the MqiI has grown considerably. When we started, we had 6 sites, and they were sort of the few who were brave enough to try this out. And to date, I'm proud to say that we've got well over 300 sites across 38 states in the US participating, and this number is growing. And so it's probably, I don't know, the apple of our eye, because we didn't really think that this is the approach that we were going to take, but it's grown. So on the next slide, in a nutshell, the Learning Collaborative has had several goals, and it's been really inclusive of driving QI, which is central to all of this, generating evidence through individual QI projects, disseminating the findings, which is foundational and fundamental to really sharing knowledge and improving overall. And then finally, educating and empowering caregivers to care for patients with chronic conditions. So on this next slide, I want to talk a little bit about measurement and how measurement is fundamental in driving change, because you can't improve that which you don't measure. And so having said that, though, I have to say that it has been quite a journey going through this quality measure development process. As Sharon alluded to and Matt described, the Academy and Avalier, we've partnered to develop a comprehensive set of measures targeting hospitalized older adults at this time. And these include 4 electronic ECQMs, a global composite measure that you've heard about, and then a set of measures that could be used as a part of CMS's Qualified Clinical Data Registry, or QCDR. Next slide, please. So we are proud to report that the 4 ECQMs have been adopted by a number of hospitals and health systems across the country, many of whom are participating in our Learning Collaborative. And those 4 measures are actually listed on the slide. They include completion of malnutrition screening within 24 hours, completion of nutrition assessment, again, within the 24 hours, a nutrition care plan, and then appropriate documentation for diagnosis. These measures were also reviewed by NQF and remain on CMS's measures under consideration list. And so we're hopeful at some point, maybe, they too will appear in the CMS's in-hospital inpatient quality reporting program. It's to be seen. On the next slide, we can go into a little bit more detail about the composite measure that Matt teed up earlier. So this composite measure focuses again on adults over 65. They're admitted to inpatient service who receive appropriate care for their level of nutrition risk or malnutrition risk. And if you can imagine, we've been pursuing the adoption of this measure into a CMS hospital inpatient program as well. And to date, as I think you've heard, it was on the MUC, it's been reviewed, the MAP reviewed it, and we're patiently awaiting to see if we get into the rule. And if that occurs, we will be thrilled. At the same time, we're also awaiting endorsement from NQF, which is also at the top of our list. And it's been 8 years in the making. Very excited about the prospects of it. And our fingers are in fact crossed. Probably our toes are crossed as well. We will get into these programs. So on slide 18, this is really, I want to share with you some measures that we modified just in the interim, recognizing that there are other folks who would benefit from capturing, tracking, and measuring nutrition. And so we created a set of malnutrition quality measures that have been included in Premier's clinical performance registry, as well as US Wounds Registry. And in both cases, we're promoting healthcare team collaboration, which is critically important, as you can imagine, with measures for physicians and RDNs reporting. And these are particularly pertinent for those who are billing outpatient Medicare Part B. And it provides them an opportunity to participate in MIPS. Many of you may be familiar with the merit-based incentive payment system, but it's just another way of sort of driving toward high quality care. We're excited that these particular measures have been renewed for 2021 reporting year. And I just want to clarify a couple of things because it could be confusing. So yes, we have 4 ECQMs. There is a global composite measure score. And I just described to you some measures that are included in a qualified clinical data registry. They are not meant to replace one another. They simply are alternatives. So depending on where you're practicing, who you're practicing with, you will find benefit in using them to serve your needs at that time. So you go to slide 19. This is really about the toolkit, as I talked about. It was important for us to make sure that the toolkit that we spent all this time and effort building and testing, that it could be made available to anyone. So we created a website to facilitate just that objective. And it has been a resounding success. So much so that our public-facing resources about the importance of malnutrition care, as well as content to support MqiI, caught the eye of the UK's National Health Service. And to date, our resources have been slightly modified and introduced and adopted in well over 50 hospitals in the UK. This was like an added bonus. We had no idea that we would have such reach with all the materials we put together. And so on an aside, for folks who've signed up to participate as official Learning Collaborative members, the website includes a member portal where we include archived webinars and newsletters and the like. And given feedback from our participants, we are happy to announce that our website has been reworked, redesigned, and will be relaunched. And so stay tuned for more information about that, but that's really exciting for us. So on slide 20, over the next couple of slides, if you can just, want to outline how we can and have leverage resources that we've created to advance malnutrition quality across a variety of conditions and diseases and across different care settings. So more specifically, it is with this dual-pronged approach, again, the toolkit on one hand and the measures on the other, where nutrition-related issues can both be identified and addressed and have led to better outcomes in disease management among patients with chronic conditions. And so in the next couple of slides, we're just going to go quickly because I want to get to the questions that I see coming in. We've convened a number of expert webinars showcasing MqiI participants' experience leveraging the tools and these quality measures in mental health. And in the next slide, you'll see in oncology. And this has been a highlight for us as we are seeing the spread, the dissemination around advancing nutrition quality among different patient populations. And in this next slide, even still, there's research being conducted within acute care settings across and within new settings of care that will enable the needs of more patients to be met and to better coordinate for these patients as they transition between acute, post-acute, and community settings of care. And this is best highlighted by these two examples, one with Advocate Health and the other with UNC Chapel Hill. I just want to talk a little bit about them because it's so exciting, again, to see this evolution after 8 years of working on this topic. So in Advocate's case, they launched a comprehensive nutrition care model for malnourished hospital patients. And in phase 2 of this project, the study focused on providing oral nutrition supplementation to patients who were discharged to home health. The data showed substantial benefits for patients, regardless of whether they were discharged to home health from the hospital or from skilled nursing facility. Again, pointing to the fact that if you identify a gap and put in the right resources, track and measure, you can actually see improvement. And they have observed this. At UNC, they examined the impact of nutrition care process improvements through the documentation of malnutrition identification and diagnosis. And the upshot of their study is that targeting malnutrition QI efforts to hospital services with higher patient morbidity was an effective method for improving malnutrition diagnosis. And in particular, in hospitals with limited resources, this can result in improved nutrition care delivery. And they actually showed that as well. And so in this last slide, the question that Eleanor posed to us as we were planning for this session was, what is the ask? What can you do? And, I would submit that there is so much work that needs to be done to achieve the goals that were outlined in the blueprint that I spoke about earlier on. And we can all contribute. So I encourage you to think about the following. 1, continue to educate yourself regarding how poor nutrition status showcases the need to better manage chronic conditions and can be supported by better clinical management, exemplified by the work that we shared today. 2, generate evidence in your local communities to continue to highlight the relationship between nutrition and better outcomes. This is particularly needed in post-acute care settings and within the general community settings writ large. And I would say complementing ongoing research that advances clinical practice and health policy reforms that improve access to quality are important tactics needed to improve Americans' health and reduce our overall burden to chronic conditions. But finally, and most importantly, and most probably related to this topic, is we would greatly appreciate support and adoption of the current nutrition-related measures. So you can feel free to simply use the measures as is, and sort of taking a page from the book that 300 other hospitals across the US are using. Or there are opportunities to participate in future public comment opportunities to provide your support for the measures that are under review. And so with that, I thank you for your time and look forward to your questions.
Wonderful. Well, thank you very much to all 3 of our speakers. We really appreciate the background that you provided and all of this information. I want to kick off with a question that we had in our Q&A function that I think was a really important one. Could you, Sharon, perhaps spend a minute helping people to understand that the difference, but also some of the conflicting issues between what's malnutrition and what's obesity, because I think that we make the assumption that if somebody is obese, they're getting enough to eat, but I think that we don't really know enough about their nutrition. So could you help us understand that a little bit?
Sure. Thank you, Eleanor. Yes, many of our registered dietitian nutritionists, as we have alluded to, we do nutrition screening and assessment for every patient. And we do have patients who show that they are obese, but they're also malnourished. And they could have other issues related to that obesity. And I think many codes of how people look at malnutrition. They think of certain factors and data that they receive from some of the labs, and they skews them to automatically looking at these subjective information that the patient, as you said, is obese. So therefore they look like they're well nourished and they're not. But in reality, they could have sarcopenia. They could have many other conditions that have led to the fact that they are could be morbidly obese, but also malnourished. And so we do have to open up our avenues. I have heard from different registered dietitians who have this issue, and many times some of our education has to continue with our interdisciplinary team members and our physicians and nurses to make sure we understand that this is actually happening, that many times the codes that we will correspond with that are rejected because, again, exactly what just I'm sure the question came through from someone. We see this all the time, that it's just something that's just assumed, and it shouldn't be. We have the data to prove that. Thank you.
Right, right. Thank you very much for answering that. So another comment that we have has to do with, sometimes we don't know that people out in the community are experiencing malnutrition. We don't know until they actually show up at the emergency room, or they're being admitted to the hospital for perhaps a workup or a procedure of some kind, and that's when we find out that they have malnutrition, and then they begin to get some of the attention that they require. Is there something that we could be doing that would help do a better job in the community, so that maybe there's something that we could catch earlier or be a little bit more preventive with dealing with people who are in the community, rather than seeing this when it's progressed pretty far and they're now in the hospital setting, or that it might even be the reason why they're in the hospital setting? And I open that question up to both Sharon and Christy.
Sharon, I'm happy to take a stab at it. I mean, I would love to have some type of screening tool that's been well validated that we could use to identify patients who may be at risk for malnutrition in the community. Now, whether or not that's feasible, right? Whether or not we can capture those data and do something meaningful with those data, that's a completely different question. But I do think that continuing thinking about raising awareness and education around the need to ask these questions around nutrition is critical. Sharon, what are your thoughts about creating a tool in that space?
Yes, exactly. And we are striving through the academy to make that happen in the community, to have nutrition screening, at least that way. That's that first level that we can continue the process of assessment and interventions. You are correct that many times our dietitians do see in the community those individuals, and it's difficult because those patients may not draw attention until there is that acute stage, and then then the issue happens when they end up coming into the hospital. It's different because we have that fine-tuned system in the hospital. The nurses work with the dietitians. They've got that history down. They're asking all those pertinent questions. We don't do that out in the community. Maybe we need to do more of that in the primary care settings, in the physician's offices.
Right, right. We have a question about the measures that you were talking about. How can we see it playing out that that use of the measure could actually turn into an improvement in the patient's nutrition during their hospital stay? So how, in terms of the measurement, how could it be used on on a clinical basis, on a decision-making basis for an individual patient, that the measure tells the clinician or the caregivers something that helps them to do something during that hospital stay that could actually make changes during that stay? Is that something that you see happening or foresee would be happening?
Yes, actually, it happens now. this is a part of that quality improvement that we'll have to have our dietitians work with our physicians once they put and diagnose malnutrition on the problem list. We need to collect that data around while that intervention is occurring in the hospital. I can tell you that many patients they're not medically stable. They're not going to be discharged, right? So that's why the length of stay continues. However, you can't let them move to the next point of care or home to make sure that they have nutrition security in the home, as well as, if they're moving to the next point of care, say rehabilitation, the handoff. Many of our registered dietitians now are working with the case managers to move to the registered dietitians in the rehabilitation facilities to make sure they have that nutrition link to move forward. But to get back to the matter at hand, a quality improvement project are those kinds of things that have to happen around exactly what the question posed.
To get to those case examples
Yes.
that you learned from. Yeah, I can.
That way we can collect that data.
Right. Yeah.
Right.
Yeah. Could you also? We also have a question about payment and how we want to see that Medicare, Medicaid are providing the reimbursement for the kinds of services that a person with malnutrition might need. So, for example, that they need that workup for their malnutrition, and that they need potentially some care, that they would potential difference in care or a requirement during that hospitalization. How do we ensure, or how do we all as the patient community help to reinforce that there should be reimbursement for any of these kinds of services? Chrissy, I know you're kind of that policy wonk kind of person. Would you have thoughts on that?
I wish I were more of a policy wonk. I'm a bleeding heart, something. I think that we should just continue doing the right thing and it'll all work out, payment included. So I'm probably not the right person to ask this question. Sharon has a better answer, I can tell.
Okay. Sharon,
no. It's this is the work that we've been making sure that we are striving. I think now the way we have embarked on today's environment, the curtain has been pulled up, right, through this pandemic. And this is not going to be the end of it. And we have serious other items that happen, whether they're floods or tornadoes, hurricanes, fires. We constantly are having these types of issues in the community. And we cannot any longer ignore the fact that certain connections of the health, and if there are disparities, social determinants of health, this connects 100% to nutrition. It must be reimbursed, those services of the registered dietitian nutritionist, those interventions that have to happen. I hand it to the dietitians, and Christy and I know we've been, as you said, we've been joined at the hip for over 8 years and working on this. And we see, I can't believe some of the ingenuity that our dietitians have had, who've stepped up to be in these leader roles and have been recognized by their C-suite. And I can tell you that they've received grants to pay for those services for their patients.
Yeah.
And literally are going to homes with the patient as the hospital makes sure that food is making sure it goes to the home to ensure that they are getting covered. And we're using every type of resources and services that we can to pay for those dietitian services. And we really would love to have our largest employer of dietitians, the VA hospital, right, along with our centers of Medicare and Medicaid services to really provide those experts their payment to help those dietitians help their patients who day in and day out, they put them first. Patients are first in the dietitian's minds.
Yeah. Necessity is always the mother of invention. So
That's right.
We are out of time, or close to running out of time. And I wanted to give Matt an opportunity for a few last comments. And Matt, maybe you could respond to, in terms of the quality measures that NQF sees, what do you need from the patient community in terms of helping to support movement of those measures or comment on those measures? Are there things that we can be doing with NQF that can help in this regard?
Yeah, thanks, Eleanor. Certainly, and appreciate all the questions and obviously the responses from Sharon and Chris have been fantastic. Yes, the patient community is very pivotal and important to the work that we do. One thing that you can always do is comment on measures or reports that we push out. And currently, right now, this measure that is going through NQF endorsement, the global composite, is up for public comment. So you go to the website, our website, and go to the Prevention and Population Health project page. You'll see the final report that you can comment on and comment for its importance, for the need for this measure, if you feel that this is important and it's a needed measure to be endorsed and ultimately potentially used within a quality improvement program. Those comments will be considered by the standing committee that evaluates those measures in our post-comment meeting, which will happen later in the coming months. So those comments will be considered and help if there's questions around endorsement that still remain. You also are able to participate in endorsement efforts and sitting in on standing committees and nominating representatives from the patient community to sit in on the standing committees and actually help with the endorsement process, have a vote in the endorsement process as well. And in addition is just outside of endorsement, when you have a measure that's being developed, sitting in through those development efforts as well through technical expert panels and providing lived experiences that would help to inform and shape the measure and measure development. So there's various different efforts, both from the development and conceptualization of the measure where the patient community can engage, as well as the endorsement efforts through NQF and participating on these standing committees and submitting public comments to the work that we do to show that there's value in having this measure, there's importance in this measure to be used out there in the communities.
Thank you very much. Matt, thank you for that answer. And thank you to all of our speakers for today. We've run out of time, but the slides will be made available. And we've had one person who's asked Matt for us to put the information about the link in the chat. So if you would do that, we'll hang on with this being open so that people can see that. If you'd be willing to do that for us so that it can be made available. And we will also try to make it available on our website so folks can link into that. Thank you everyone for joining. We really appreciate it. And thank you to our speakers. We'll all clap for you as though we were all in a non-virtual format. Bye everyone.